All right. I think that's enough reminders. If you're ready to get started, I want to see a let's go in the meeting chat. I know we have a bunch of people on, so go ahead and let me know if you are ready to get started. Truly, I'm looking for a couple of chat messages here from our attendees that they are ready to get started, and we'll go ahead and have Alexis. Oh, there's the excitement. Oh, it's coming in now. Excellent. So Alexis, I'll have you come off of mute and take it away.
All right. Well, hello everyone, and welcome to the 16th annual AMC conference. Our conference is now old enough to drive, babysit the neighbors, get a job at McDonald's. It's a really exciting time, and obviously this isn't how we first saw a conference going. We really miss seeing all your faces, but I love seeing all of your names in white block letters too. Go to the next slide and we'll just go over what this conference is going to be the next couple days. So conference is going to be every night. We are going from the 18th to the 24th. Next slide. It's going to be 2 speakers every night who are professionals in the world of AMC. And on that last night for closing ceremonies on the 24th, yes, that is when we are announcing next year's in-person virtual conference. And so that will eliminate about, I think, 3/4 of the questions coming in now. So gotta wait for that one. All right, next slide. If I didn't introduce myself earlier, my name is Alexis Record. I am on the executive board of directors. My position is the secretary. I have 2 kids with AMC at home who are 10 and 13 now. And I'm really excited to be here. And I'm excited about the speakers I am introducing. And it's not the first time I'm introducing these specific speakers. These are people who have a passion for AMC, research, and medicine. So I'm really excited to be here. Our agenda for tonight will be our first speaker, Dr. Hyer, a break, and then our second speaker, Dr. Nichols. At the end of each speaker, we will have Q&A, and like Jean said, put in all your questions now. You can put them in the chat. If you're following from Facebook, you can put them there. We do really encourage you to register for this conference if you haven't, so we have an idea of who you are and so you can interact with our speakers more directly. Next slide, please. All right, about us. Who is AMCSI? We kind of say the AMC conference, and it's technically the AMCSI conference. We are our mission, and our mission is to support those with AMC. So our mission is you, our mission is us together. And our vision is that one day someone will be born with AMC and they will have all the information, support, and equipment and community that they need to thrive. So you can read all the mission statement, vision statement, but that's who we are as an organization. That's our heart. We're also a 501c3 and have our professional, legitimate business side as well, but that's our heart. Next slide. And we encourage membership. Today we're doing a special deal. If you become an AMCSI member, conference day will be completely free. And wait, hold on, this just in. No, wait, it's free anyway. But if you become a member, you join us in supporting this community, and that's our mission. It's going to be $15 for an individual, and it is a family membership option. There's lifetime membership options. It will be this and more available on our website, and knowing Jean, she's probably already put the link to that directly into the chat, so you can check that out, but it's amcsupport.org. Next slide. All right, now you may be getting a little confused. If you have a pop-up on your screen, you might think, if you're new to Zoom, oh, can I touch this? But yes, you can. I'm going to do it too. We're going to do a poll just to find out how many people showed up today are actual members that have done a paid membership. Oh, excuse me, paid membership. And go ahead and take your time to answer that question. I'm going to stall a little bit.
You're doing a fabulous job, Alexis. I think we've started to get our response in. So I'm going to go ahead and lock it down and let's share our results. So we do look like we have a few members on, but we have a lot of people who are planning to join. So we've got that link in the chat to help you do that for those who are looking to do that.
Perfect. Perfect. All right. And besides becoming a member, that gives you access to us, it allows you to join the board if you want, which is pretty glamorous. And it gives you access to our newsletter and other things, and just lets us know, hey, we're still in this, the support's still coming, we can move forward. But that's not the only way you can support AMCSI. Obviously, as you see on your screen, there are lots of everyday things you can do. If you're on social media, there's fundraiser options. If you are shopping from eBay, we just recently bought a manual wheelchair on eBay for $50. And some of that, when you do the charity link, can go to AMCSI, so little ways to help. All right, last slide, next slide. All right, poll number 2. Now this is just learning more about who's here today. So who's interested in these talks and who had the time on a Monday. So go ahead, in the first one, you can answer where you're from. The second one, you can check multiple boxes. So if more than one applies to you, go ahead and check that out.
I feel as though I need to let you all know that the audience last night, we got to about 75% of them responding. And I know that we can get 75% of you all responding tonight. I know you can do it. We're almost there. About 65% of you have done it. So you may need to scroll up and down to see the full questions, and then just hit that submit button as soon as you are done with your responses. All right, so I think just in the interest of time, why don't we go ahead and, ooh, we're almost there. All right, let's just take a quick look. So Alexis, it looks like the bulk of our audience is coming from either the North or Southeast US. We do have some international attendees and some great representation from the Midwest and Western US. And then again, the largest percentage of our audience members are here because they have a child with AMC, but we do have a number of other individuals or adults with AMC, or they're either caring for or just simply curious, or they love someone with AMC. So that's great to see that.
Okay, great. Thanks so much, Jean, for that. And that kind of tracks with what we expected. Greenville and DuPont are not exactly here in California with me, and they do focus on our younger AMCers. So parents of AMCers would make sense. And we are so excited. We're so excited about these speakers. They have been at conference in person. They have been extremely involved in the AMC community for the last several years. The first speaker tonight is Dr. Laura Hyer. You can read her bio, but I just want to say that I am on the other side of the states, and I have heard of the Greenville Method. It is cutting edge, it is world-renowned, and it is getting mention in AMC circles. So we're extremely proud to introduce Dr. Hyer. And we'll even unmute her.
Yes.
That's a bonus to you all.
All right. Can you hear me now, Alexis?
Yes, thank
Okay.
you.
All right, very good. All right, let me go ahead and share screen. And let's see, hold on just, all right. Okay, is that going through all right too? Okay, very good. Just wanted to make sure. Well, let me just start off by saying welcome to the 16th annual AMC conference. It's truly such an honor to be able to speak with you tonight, and truly an honor to just get to talk with you about our approach to managing the lower extremities in kids with arthrogryposis. So I want you to, as you've already been very encouraged, to chime in with questions. Hopefully we'll have plenty of time at the end to answer any questions that you have. I'm going to flip my, this way you can see my pointer a little easier as well. So, okay, Okay, let's see. Okay, so here's just a brief overview. We're going to go over some basics and then move into orthopedic management through the stages, and then kind of go through our approach to lower extremity management, and then wrap up with some questions. So let's go ahead and jump in. Those are my two little ones. So I think it's important to start with why arthrogryposis, why something that affects, 1 in 3 to 10,000. Well, I mean, I think the short answer is just, I feel like this is my life's calling, but the longer answer is I started in Shriners in Greenville in 2016 down here in the Southeast. Pretty soon after, my boss here said, well, we need somebody who's more in tune with arthrogryposis care. So I went up to Montreal to an AMC conference up there and met this guy who I'd say probably everybody in the AMC community has met. And he goes almost without introduction, but Dr. Van Boss, and very quickly realized like we have a lot to catch up on in Greenville. And then as many of you know, Dr. Zlotlo, or Dr. Z as we call him, comes down every few months to Greenville, at least pre-COVID, and we're hoping soon to start that back up. But between these two men, I just saw a gap that needed to be filled, and I saw potential in our team here to fill that. And so I just love this quote by Isaac Newton that says, "If I have seen further, it is by standing on the shoulders of giants." And so giants, are ones like Lynn Staley and Judy Hall, who wrote this book, which if any parent hasn't at least glanced at, I really suggest that you do. I think it's full of information from A to Z on caring for a child with arthrogryposis. The illustrations and clearly some of the attire is a little dated, but some of that stuff is coming back. I'd also say the learning continues. Unfortunately, we just kind of had a damper with COVID on meeting in person, but we're hoping to have another international symposium soon. Myself and Dr. Z traveled to Russia to learn techniques from the doctors over there. And then I'd say my colleagues, both here, Dr. Feldman and Dr. Nichols, and abroad, have just taught me so much. But I would be remiss if I didn't say that the people that have taught me the most are my patients. Even today, I learned from a mom talking with her on the phone about this thing called the lift spoon. Have any of you guys heard of the lift spoon? But it's just a nice little piece of technology to help people to eat. So every day I'm always learning from the people that matter most, and that's my patients. So just a brief word on what is Shriners Hospital, because many of you may not have even heard of Shriners until you came across somebody with arthrogryposis. And so we are a healthcare system, about 22 hospitals. Our primary focus is pediatric orthopedics, but some of our sister hospitals also do burn care and neurosurgery and spinal cord injury. We have a 3-part mission, which is first and foremost patient care, but then also clinical research and medical education. So it's very common if you come to Shriners that you will see a resident or a medical student coming through. And then we take care of kids regardless of ability to pay. And then we also take care of kids from birth to age 18, every now and then under the radar till age 21 as well. So this is just kind of a couple of pictures of our hospital here in Greenville. We have an outpatient clinic where we do all of our casting and clinical care, an operating room where we do both inpatient and outpatient surgeries, our prosthetics and orthotics lab, which anybody with arthrogryposis is well acquainted with, our therapy gym, and then lastly, our motion analysis center, which I think is something that sets some children in hospitals apart from others, just in our ability to analyze the way a child walks. So transitioning into arthrogryposis, Harold did a great job a few weeks ago, just going through all of the nuts and bolts. So we'll just touch on this real briefly, because if you're living with or have a child with arthrogryposis, chances are you know many of these things. But Arthrogryposis multiplex congenita, or everybody, you know, we just call it AMC for short. It's not an actual diagnosis, but more of a description, with arthro meaning joint and grypos meaning curve. So stiff curved joints. And then the formal definition is multiple non-progressive contractures affecting 2 or more body areas, which are present at birth. As we know, there's over 300 diagnoses that have arthrogrypotic characteristics. So what causes it? Well, there could be a number of reasons, be it a maternal illness or a defect in the muscle, but the common theme is limitation of fetal joint mobility or fetal akinesia, and that leads to loss of muscle mass, increased joint capsule collagen, which then leads to stiff joints. So amyoplasia is our most common type, or the classic type of arthrogryposis. It makes up approximately 1/3 of cases. And if you just break down that word, A means no, myo, muscle, and then plasia, growth. So failure of muscle growth. And then, so what specifically causes amyoplasia? Well, to be honest, we just don't know. We have examples of identical twins where one is typically developing and the other is affected. And then it affects children of all nationalities and backgrounds, so that we don't really have a known genetic or environmental cause for amyoplasia. However, we know that it's a non-progressive disorder. It's at its worst at birth. It tends not to involve other major organ systems. Sure, there's, you know, little things here and there that can be affected, but tends to keep everything else normal. And then, as anybody with that knows anybody with amyoplasia, they're always very smart. So of normal intelligence, if not above normal. We know that most of these children then grow up to be adults that can get higher education degrees. Their life expectancy is normal. And then what I need to remember most of all is that their sensation is normal, and that they feel everything normally. So natural history, most all of these children do have orthopedic problems that require attention, and it can be severely disabling. But the good news is that 85% of kids with amyoplasia can take care of themselves as adults, and 75% can ambulate throughout the community, which I think is terrific news. So transitioning into what are our goals in managing these kids? Well, I think, you know, as an orthopedic surgeon, my #1 goal is just maximizing their physical function. And we do that by correcting deformity through both surgical and non-operative treatments, trying to teach these children to facilitate their own self-care. And we need to do that in a way that that controls their discomfort, both now and then looking into the future, trying to prevent pain in the future. So those are our goals. What are our principles? Well, we have to consider the whole patient. You know, as us ortho surgeons, sometimes we get very tunnel vision on a knee or a foot or a hip. We need to look at the whole patient, and that goes just, you know, not just their physical body, but what their family situation is. What are their resources? Are they from, you know, an urban area where there's sidewalks and ramps everywhere you go, or they live out in a farm? You know, and have different challenges. And then also, you know, maybe not our amyoplasia kids, but our other children with arthrogryposis, they may have different cognitive abilities, and are they going to be able to go through the therapy and the rehab? But I think we need to focus on, can they do something efficiently? And then how they do that is of secondary importance. I just love this slide from Lynn Staley's book talking about walking is not the key to success. And then I also love this new phrase I've adopted from our friends in Poland. It talks about like functional locomotion. You know, sure, we love kids to be able to walk, but more than anything, we want them to be functional and get from A to B. So, so our approach here in Greenville is very much a team approach. While there are many spokes on the wheel, I'd say the three legs of our stool are orthopedic surgery, physical and occupational therapy, and then orthotics. And really, if one of the three were to go away, the stool would topple over. So we very much embrace a multidisciplinary approach and try to see the whole child. And then we embrace a both and strategy. We believe that walking is good and surgery embraces are good. We believe that sitting is good and wheelchairs are good, and that we believe in individualizing plans to each patient. So here's just a picture of our team. Again, we have myself and one of my colleagues from the surgery side, Katie Ward's one of our physician assistants, and then our therapy team, as well as our orthotic team. So let's talk about a couple of those legs on that stool. So we'll start with therapy. Anybody with AMC knows that this therapy they just become best friends. And so what are our therapists trying to do? They're trying to gain motion through stretching. They're trying to teach strategies for activities of daily living, so these kids can become independent. Of course, they help patients recover from surgeries, and then they assist in achieving milestones, whether that's standing or walking or learning to navigate stairs. So here's a picture of our rehab team, obviously pre-COVID, because we're not wearing masks there. But really and truly, like, I believe that our therapists are truly the hidden gems of our program. And I love that department with all my heart. So, because I can tell you, I certainly don't get smiles like these in clinic or when I'm doing stretch casts. It really takes a therapist to bring out this side of these children. So, and then let's talk about that second leg, orthotics, braces, braces, braces. It's just always a recurrent theme when we're talking about arthrogryposis. So braces are to assist with function and also to prevent deformity from occurring. So we have our short braces, or our AFOs, for anybody fresh to arthrogryposis, that's ankle foot orthotic. And we have our knee ankle foot orthotic and our hip knee ankle foot orthotic, and the list can go on. And sometimes we'll also put in some shoe wedges. If we can't get the foot flat on the ground, sometimes we'll bring the ground to the foot, and those are some pretty big shoe wedges. So most kids will probably spend more time in braces than out braces, and will have an increasing level of bracing depending on their level of function. So now let's move through some of the orthopedic management through the stages of life. And so something I just until recently have not really spent a lot of energy on, but I'm learning is to even try to get to these children before they're even born. So I really have Dr. Sarah Lehman to thank for starting this website and this initiative called Take Time for AMC, and that's trying to educate the OBGYN community to take time and look and see, like, you know, if you see a club foot or if you see something different, like, look and make sure these children are moving their legs and their arms, and if not, like, let's get them further evaluated. I think it's important for if you know you're having a child with arthrogryposis, to establish care with a maternal fetal medicine doctor and make some decisions on, like, is it safest to deliver you know, more naturally and have a vaginal birth, or should you choose to do a C-section? You know, at the time of birth, it's that's a great time to collect blood. As we know, a lot of our children with arthrogryposis are hard blood sticks. So that's a great, you know, avenue to just get an easy sample. And then consider a prenatal orthopedic consult. I think, you know, before the baby is born is a great time to meet the team, and maybe at the permission and guidance of your OBGYN to start what we call, what we'll phrase, in utero physical therapy. And that just means, like, very frequent light to moderate physical activity, nothing too intense. Every now and then massaging the womb or trying to wake that baby up and seeing if you can get them moving. And then perhaps increasing that little bit of coffee you're allowed every day during pregnancy. Infancy. So we in Greenville love to get to these babies just as soon as we possibly can. We love to get to them even in the first couple of weeks of life. Not only is there just something extra cute about a child with arthrogryposis, it's also the golden window of opportunity to increase motion. So these babies come to us and they're at their worst, but they're actually at their best when it comes to actually being able to make gains with conservative treatment, be that stretching or casting or just therapy in general. I can't understate the importance of bonding. Just those first couple weeks, it may look different depending on whether or not your baby has to stay in the NICU or if they have some other diagnosis going on. But raising a newborn is hard enough. These are times to really call on friends and coworkers and just your village to help you. But I think it's really important to take time to bond. This also applies to adoptive families. These children may be older when they come to you, but when they're coming to you, that's time 0 for being in your family. And it may not be time to rush to the orthopedic surgeon. I think it's important to take at least a few weeks, maybe a month or so, to make sure that that bonding has taken place. So, and then let's talk about orthopedic surgery in infancy. Well, the feet tend to be our first aim, really the pendulum has shifted, where it used to be very heavy surgical approach, and now we really try hard to do most things with casting and then just minimally invasive procedures, both for the clubfoot and the congenital vertical talus. At the knees, if the child comes to me with flexed knees, we're going to try to work with therapy and stretching and potentially some casting to straighten them. And then vice versa, if the knees are straight, we may try a little bit of stretching to bend them, being very careful that we bend in the correct plane. And then lastly, the hips. Early infancy, we kind of may turn a little bit of a blind eye apart from doing some stretching, but later in infancy, maybe early toddlerhood, we'll discuss about if the hips are dislocated, we'll discuss the risks and benefits of trying to reduce them. And if they're contracted, again, we're going to stretch them, maybe consider an osteotomy later. So I'd like to weave some stories into my talk. And so I'd like for you to meet this little guy, Asher. So this is a picture of him when he's first born. You pretty clearly can see a little bit of that birthmark on his face, the straight elbow, no creases in the elbow, the fingers held straight and the wrist bent. The knees are bent in flexion, and then clearly has a moderately involved club foot. And so Asher came to us when he was about 8 days old. We got him in cast right away. Clearly that didn't put a damper on his joy. And I can fix legs, but that hair, he just came by that naturally. So I had nothing to do with that. But this is he and his family at last year's Arthrogryposis Awareness Day. So I just wanted to show you a few videos of him, and let's see, okay. I'm trying to get the second one to play. I had him going, but I guess not. See if it rolls to the next one. But I just wanted to show you, like, this is when our babies come to us. Now, granted, our Asher probably has a more mild case of arthrogryposis, but this is truly like the potential a child has when we're able to do early intervention, get them involved with therapy right away. I mean, there he is out playing soccer. There's really not much that's going to slow this young man down. So I show that not to try to create false hope, but like this is these are things that can happen when we intervene early. So, and I just love, he can hit a ball better than my 3-year-old son. So I'd say that was a strikeout there. So good job, Asher. So from myself and everyone in Greenville, we really do love our arthrogryposis babies and really do try to spend a good amount of time investing in them. So let's move on to our toddlers and our preschoolers. Our goal here is to try to get as much, if not all, of our major surgical interventions out of the way before they start school. We know these kids are bright. We know they need to be in school. We don't want our orthopedic surgeries and our recoveries keeping them from that. So this does tend to be a very busy time, orthopedically speaking. So back to the feet, our nemesis is recurrence. And so oftentimes we're making lots of modifications to the bracing. We may be repeating some casting versus a tenotomy, versus some children that come to us a little bit older, that 3-4 year age range. They may need a little bit more aggressive soft tissue release, but those are conversations we have on an individual basis. Back to our knees, we're going to push hard to straighten them. Depending on just how stretchy the kid is, we may try some stretch casting versus going forward with some surgery, doing a posterior release and a femoral shortening. Personally, I follow a pretty similar protocol to what Dr. Feldman does with my own touch on it, but I found that to be fairly effective in my hands. And then down to the hips, we're gonna keep stretching, but we're also going to entertain, like, do we need to, does this hip need a little bit more in the form of a reorientation osteotomy, or should we, or if the hip is dislocated, we'll have conversations about the risks and benefits of reduction. So up to school age, hopefully by this point, we're mostly in a maintenance phase. We're always going to be vigilant to watch out for contractures, particularly around the feet. And then we may need some stretch casting or repeat tenotomy. For our knees, hopefully we're, if our child's grown up with us, hopefully we're in a good position. We may need to do some touch-up surgery in the form of guided growth, or if we have had a significant recurrence and contracture, we may consider doing an extension osteotomy. And then again, in our older children or our children adopted, they may need more aggressive surgical intervention on a case-by-case basis. So something that I think sometimes we just get so distracted with all of the surgery that's necessary that we kind of turn a blind eye to the actual quality of the bones. And so I think even in the infants and preschoolers is important, but it's especially important in these school age kids while they're doing so much growing, that we try to build the best bone we can to last a lifetime. So not only are we trying to prevent fractures but in childhood, but we're trying to prevent them as adults. And that comes in the form of optimizing their calcium and vitamin D, sometimes getting them on some heavier hitters in the form of bisphosphonates. And we may partner with our endocrinology friends in this journey. This is just an example of how a screw backed out just because this child's bone was a little bit weak. And then last but certainly not least are our adults. I think it's always important for our adults to maintain contact with an orthopedic surgeon or a physiatrist, that you need somebody just to serve as your primary care physician for your musculoskeletal needs. So the physiatrist, or sometimes they're called PM&R, or physical medicine and rehabilitation, they tend to be non-operative orthopedists, and they may be best suited as that point of care. Because then unfortunately our adult colleagues tend to only want to see a shoulder or want to see a hip, and they don't want to see the whole picture. And so our PM&R colleagues can sometimes do things like manage the wheelchair and orthotic prescriptions, and they also work closely with vocational rehab, so that if you need something specific for your work, they can help with that. And then as we just finished up on, it's important to maintain that bone health, maintain getting that appropriate amount of calcium and vitamin D to try to prevent fractures. And then many of our adults do have pain on a daily basis. One recent study showed that they tend to be overcomers of pain, but it doesn't mean that they don't have it. And sometimes that's in the form of arthritis of a hip, a knee, or a shoulder. And so there's really not a lot of literature. I've only found a couple of case reports, but anecdotally, I have talked to some adults who have undergone a hip or a knee replacement, and usually their first line is, "I wish I would have done that sooner." Not everybody, but usually. So this will help to decrease pain. It may not increase range of motion, but again, we don't have a lot of literature on that. I'm hoping with the talk later on this week from the adult orthopedists, we'll get to learn more about that. So now let's move on to the Greenville method to lower extremity management. And so this talk has changed from a couple of years ago when I gave it, and I kind of went through all of the nuts and bolts of, okay, this is how I do this osteotomy and this release. And I just found that's maybe more appropriate for my my surgery colleagues, but maybe for your parents, what you want to know is just like, well, what's the outcome going to be? So I'd say our experience here in Greenville is probably less of an algorithm of like, okay, at age 2 we do this, and age 4 we do that, and more of a journey. Each one of you, patients and persons with arthrogryposis, you're all very unique, and you all have your own set of challenges. Each child just that has has certain things that are going well for them and certain things that they need help on. And it's really hard to pin down an algorithm to, to treat the whole population of arthrogryposis. I think everybody needs something a little special, a little individualized. And so it's a journey. And any of my patients out there will say, I use this phrase a lot, and I say, it's going to have some bumps or twists or turns, but we're going to the destination, and we're going to go there together. So again, circling back, we really do have a multidisciplinary approach. We try to see the whole child, not just their lower extremities or their extremities. And again, we do embrace a both and strategy. We see walking as good, but sitting is good too. So if you had to really pin me down, kind of circling back to our last section, our algorithm is trying to get to the feet as infants or as young as they can, and then address the knees and the hips in the toddler or preschool years. A concept that I've kind of adapted from treating children with cerebral palsy is this concept of a SIMLS, or let's break that down, single event multi-level surgery. I'd say the field of arthrogryposis is maybe just a couple decades behind the field of cerebral palsy. So we're getting there, but about 20 to 30 years ago, the experts in cerebral palsy realized, like, we're operating these kids about once a year, and they called it birthday syndrome or birthday surgery, where, okay, they're 6 years old, now they have tight heel cords, so we'll take them to the OR for a heel cord. And then they're 7 years old, and oh no, now their hamstrings are tight, so we'll go ahead and release those. So, it just became this chronic cycle of the child would have surgery, they'd finally recover from surgery, and then they would need another surgery. And so this concept of SIMLS came out, and it came where you just truly evaluate the whole child, the whole lower extremity, and what is this child going to need to stand and walk. And so now there is a limit to this. Like, you can't do absolutely everything all the time, but you have to be reasonable, you have to be safe. But we do try very hard to take whatever is necessary to get a child from wherever position they're bringing to us and get them into a standing position with the least number of anesthetics. The thing we have to be very careful about is some of our kids are very stiff and they only have a little arc of range of motion. And so we just have to be careful that we don't compromise our sitting ability. I'd say probably the vast majority of us right now are all sitting while we're watching this presentation. And so we have to be very careful that we don't compromise that sitting ability for our kids with arthrogryposis. So what does that look like? That looks like kind of one of my, I guess, maybe more common packages, if you will, would be to do hip reorientation osteotomies. And so that's bringing the leg, if it's abducted out to the side, trying to bring it underneath the trunk of the body. And we may accompany that with some soft tissue releases, and then doing some posterior knee releases, and then the Achilles tenotomy. So that's taking a child that's maybe in that, more classic frog position and really trying to bring the extremities under the torso, straighten the knees, get the feet flat on the floor, get the child ready to stand up post-operatively. And so our hope is that allows a less overall convalescent time and decreases that risk of recurrence while we're waiting on one site to heal and waiting to operate on the next. So let's run through the case. This is one of my patients. He was adopted, and this is him preoperatively. He can move, he can walk, but it's very hard because he can't get his legs underneath his body, and his knees are flexed and his feet are in equinus. So we did that package that I just mentioned, the reorientation osteotomies, knee releases, Achilles tenotomies. This is him 4 months after surgery. And then a year after surgery, man, he's got that walking down. So he is confident and he is proud. So I would be remiss to say that it's always a smooth road. It's not. These are really tough cases. I mean, there's a reason why there's not many orthopedists that are treating arthrogryposis. It's hard, and it really takes a team approach to do that. So there's more literature than ever, but to be honest, compared to other diagnoses, we don't have much to go on. There's not very many long-term studies. So a little bit of this is best judgment based on some case series and other things that are published. And we just have to be honest, sometimes the outcomes don't go the way we're hoping. I think everybody needs to know that rehabilitation, especially from these big surgeries, is a long and lengthy process. surgery is in no way miraculous. I can't take a child that has no muscle and have a surgery that makes muscle. I can only try to put the extremity in a more functional position. And I'd say, surgery is really just unlocking the door. The families really have to commit to the daily therapy to really push that door open and get that optimal outcome. So, and then recurrence is our nemesis. Everybody knows that those joints just want to go back to where they came from. If we're not really careful, and honestly, even in the best of hands, the best of braces, the best of therapy, we still battle recurrence. So, but my team and I are on the journey with you, and we'll do everything we can to see you through. I'm going to continue to work with colleagues both here nationally and then across the seas too, just to find the best solutions. And I'm young. This is going to be my life's work, and I just hope to grow with you guys. So this is definitely a journey of patience, persistence, perseverance, and hope. So let's go through that. So patience, this is a little guy that came to us. He was about 11, 12 months in this video, and really had no treatment at all. So you can notice he's got the classic club foot on his right, more of a vertical talus on his left. Lots of therapy, lots of waiting, but this young man's finally up and walking. And this video is actually a year old. He finally surprised us at his last visit. He's like, I've got a surprise for you, and he just stood up and walked. So that was thrilling. A lesson in persistence. This girl, man, she wanted it. She wanted it bad. We can clearly see she kind of got to the same kind of flip-flop foot deformity going on. And then in just a minute here, she's going to show us how she moves. You can almost see that callus right there on her knee, but here she goes. So she is persistent as all get out. Here she comes. So, and then, a year later, lots of therapy, a little bit of surgery on her feet. There she goes. And then with braces, man, she's got it. I'm going to show a short clip of her running here in just a second too. So, yeah, I can't create those. The smiles come naturally. I can't create those smiles. So, but she certainly is thrilled. It's a lesson in perseverance. You may or may not know this family, but man, we walked the journey, and the journey's not over yet. But a lot of perseverance, a lot of just partnering together. And he's finally up. He's taking steps. Can't tell you how proud I am of him and of his family, and just all of the hard work and dedication they put into getting him to this point. And the journey's not over. So I'm really thrilled to see where this young man goes. And then this is him finally doing a little bit of standing independently. Again, I'm just so very proud of him. And then a journey of hope. This young man came to me. He was already 3.5. Clearly, he's pretty fast on those legs. So we had a big heart-to-heart of like, okay, well, how are we gonna, how are we going to help him? Like, what can we do? And so again, as you can see, this video is taking place in our therapy gym. I really truly value our therapists' opinions. And so we did very similar package to that first young man I showed, with the reorientation osteotomies, a little bit of stabilization of his hip, releases around the knees and the ankles. And this is him taking some steps for the first time. And again, like, there's not a price tag on the joy on that boy's face. So, and then of course we love to have fun too. I'm a little jealous of my therapists. They get to play games and cars, and so here he goes. But this is him standing independently for the first time. And then moving, of course, they love to play. They just love to have fun in our therapy gym. And then this is, I actually got to see him today, so we snuck in a video, but he's taken off with that walker. I'm thrilled for the journey ahead for him. So what's in our future? Where are we headed? Well, I think it starts with research. We owe it to you guys to do better research. While arthrogryposis is rare, in the year 2021, we can bind together and make better studies. And so that starts with our AMC registry study. Perhaps some of you have already been approached to be part of this. It's a multi-center study started at our sister hospital in Montreal, but we're looking for a cause for arthrogryposis, and then we're looking to see what is best practice, what are the best interventions for these children, and then also looking at genomics to see is there a genetic cause or common link with these kids. Many of you parents have been asking for a growth chart, and not to spoiler alert, we're working on it, but this is some of our preliminary data comparing our AMC kids and then against the 10th, 50th, and 90th percentile. So we're hoping to have that out within the next year. And then another study that we recently did for any families that come to Shriners, we often have you fill out that promise survey or that iPad survey. And so you may just be bored of taking it, but we actually do use the information. So this is a review of children with arthrogryposis who have taken the survey, broken down to all together, amyoplasia, distal arthrogryposis, and then just other diagnoses. But we can see we have work to do for our mobility. Most children have a moderate impairment in their ability. They also have a moderate impairment in their upper extremity function. We can see specifically, we have a lot of work to do with our amyoplasia kids, that they're severely involved. And so that's a call to us as surgeons caring for these kids. We have a lot of room for improvement. But the great news is that most of our children have scored within one standard deviation of pain interference. And then I made this one kind of yellow green, just the way that the scores are interpreted. But most of our kids have very good peer relationships, good to excellent peer relationships. It's anybody who knows anybody with arthrogryposis would know that without a doubt. And then lastly, kind of dovetailing from that score on the upper extremities, we're looking into developing a metric to help us understand upper extremity function in arthrogryposis better. And so this is also an initiative taken by our sister hospital in Montreal. And I don't mean to steal their thunder because they're going to have their own presentation in a few days. But I just want to, this is where the future is we owe it to you guys to do better research, come up with better techniques, or better equipment to assist with maximizing your function. So let's just do a wrap up. And I am pleased I'm a few minutes early, so we'll have plenty of time for questions, should there be any. AMC is a condition of hope. I show those videos to show kind of kids at different stages, that it's definitely a journey that, you're dealt a hard set of cards, but we're going to try to partner with you and make the best of it. AMC is very treatable. It's not curable, but it's definitely treatable. We very much focus on a team approach and family centered. Our motto is together doing the right thing the right way every time for every child. That's what we really strive for. And we at Shriners are here for you. We want to be there, be it you're a mom that just found out she is expecting a child with arthrogryposis, or you've adopted a child from overseas and are anticipating their home arrival. We're here for you however we can help. So I'd like to open up the floor back to our moderators for any questions. And I just really appreciate you guys tuning in, and thank you for your time. So.
Okay, thank you so much, Dr. Hyer, for that. I can fix legs, but I can't fix that hair is my favorite thing you've ever said. And we do have several questions, so we'll start with the ones that came in first and move our way down, and I'll have my alarm set for 8 so we don't run over. But yes, first one up is more of a comment. Yes, we love the spoon. So I'll turn it into a question for the rest of us. What's the spoon?
Okay, so I just learned about it literally today, but it's called the lift spoon, or forgive me if that's not the exact commercial name for it, but it is a spoon that has a weighted, like the spoon has a weighted little cup to it. And so when you go to get your soup, you don't have to rotate or supinate your hand. Like you can keep the spoon, like you can just hold the spoon, and the cup part of the spoon will stay level the whole way. So you don't have to risk spilling your spoon. So I think it's great. Like, I think I might use one myself so I don't spill on myself as much stuff. But, you know, particularly for our kids with again, that mom just told me about that over the phone today. And she's like, it's really changed my son's life. Like, they were looking, trying not to get commercially biased, but they were looking into, you know, machine to help him to be able to eat independently. Another family recommended the spoon. And she says it's really, yeah, there we go, the liftware. She says it's really changed his ability to be more independent with his eating. So anyways, that just an example of how I learned from you guys all the time.
Okay, so I take it you lift the spoon yourself and it moves down. It's not like the OB that does everything for you.
Correct. Yeah. Yes. Right. It doesn't, the OB does everything. This, I think if you have, again, I haven't gotten to play with it. I just learned about it today. But it sounds like it just keeps the food level so you don't spill the food while it's on your way to your mouth.
Okay, awesome. And let me ask you 10 more questions about the thing you just found out about today. Hold on. No. Does Greenville do something different from Philadelphia? Can we get the Greenville Method with Dr. VB if we see him?
So I think, I really have nothing but good things to say about Dr. VB. We do approach, I'd say we approach our hips very similarly. We approach our knees a little bit differently. He will lean more heavily on the Elizarov frame. I'll lean more heavily on postoperative casting. I think that's also what distinguishes me from Dr. Feldman. I've just found more success in my hands if I place the knee in a cast and get the rest of the stretch that way. Again, so there's, yeah, I think, I think Harold and I, we partnered together on a lot of these kids. And I think we have just the utmost respect for each other. But we also agree to disagree on some nuances. No, I think if you go to Philly, you're going to get the Philly method. If you come to Greenville, you get the Greenville method. But I think they don't need to be, I think they can be complementary, I guess is what I'm trying to say. Like we really try hard to work together and do whatever is best for the patient.
I love it. My next question on the list is you mentioned the AMC text atlas or the textbook early on in your slides. Can you mention the name of that, the author again, and maybe we can get a link?
So it's by a guy, Lynn Staley, and he's really one of our pillars in pediatric orthopedics. He's written a number of books. But Lynn Staley, and it's just called Arthrogryposis, a text atlas. And I am 100% sure there's a link on it on the AMC support page on suggested reading. It's book length or short book length. I think it's about 100 or 120 PDF pages, but it's really got a lot of A to Z. I'm often humbled when I just take time to go back through it again. I'm like, wow, I thought I was original in my idea, and there it is. Judy Hall, she had that idea, or Dr. Staley had that idea. So it's again, not a perfect book and a little bit dated, but still has some really good information in it.
Okay, great. Do your therapists train other therapists? What if my PT or OT wants to learn from you? Can I set up a day to shadow you?
Yeah, we would love that. It looks a little bit different in this post-COVID era, but I think the tide is turning now. So we always say, I always tell families, like, our purpose here is not to replace your community partners. Our purpose here is to partner with your community therapists. And we really want to embrace, we want more people on our team. It's not us versus them, it's we're all on the same team. And so that means our therapists do spend a tremendous amount of time talking with the community therapists and making sure they're understanding what's happening on the home front. I can 100% say that if a therapist treating a child with arthrogryposis wanted to learn more, I think our therapist would welcome that with open arms. Again, we want knowledge spreading. We don't have a corner on it, and we want more people aware of good methods of treatment. So yes, I think just I guess a little technical point would be just navigating this post-COVID era. But I think with things opening back up, we would surely welcome any therapist that wants to come work with us for a period of time.
Great. This is a question from one of our adults. Does Greenville know of a hospital or facility that will specialize in OT or PT for adults with AMC?
Yeah, and I think that's I don't have a specific place, but like for example, we share a roof with the county hospital right next to us through Prisma Health, and they have a rehabilitative hospital called Rogers C. Peace, and there are a number of physiatrists there that basically run the hospital. They do have like for example, an OT need. They do have like a driving simulator to test out like different equipment that you need. And so I think it's gonna, yeah, we don't necessarily like have a one and done place that we can send our adults for their PT and OT needs. I would really suggest just looking for a physiatrist to establish that orthopedic primary care, and then kind of filling in specific needs from there.
Okay, great. And then I have a similar question. Is there a list of orthopedics specializing in AMC across the country for the Shriner system or overall? Do you have a resource for that?
Yeah, I'll again spin it back to the AMC support page. I think they have a list. I'm sure Ani is on, and her team is on it just to keep that updated. So I think that's probably one of the better lists to go by. And then I just say, like, I think both the AMC public group and then the private moms group is where a lot of the information of like kind of where should we go to happens.
Okay, great. And yeah, I love that answer. And I would just add to it for everyone listening, if you have a doctor you love, email that doctor's info to AMC and they will add it to the website, and they want those resources. Is there a time, oh, I love this question. Is there a time when it's too late? If my child is 9 years old, can they come? They're not a baby.
Yeah, absolutely. We embrace children of all ages. Unfortunately, at Shriners, we do kind of have a soft stop at 18. But yeah, we embrace children of all ages. Can we guarantee the same outcomes or the same treatments in the older child as we can in the younger child? I don't, you know, we have to, if we don't try, we'll never have the opportunity to succeed. I will say the stakes may be higher, and we may not be able to guarantee as good of an outcome. But certainly it's always, yeah, certainly we'll embrace any child with arthrogryposis with open arms and walk with them on the journey.
Okay, great. And this, I'm going to turn this into two questions. One, our child's left hip is dislocated, but he chooses to use the left more than the right, which is longer. Any tips or tricks to get him to put equal weight on the right?
That's a loaded question without seeing the child. Perhaps a shoe lift on the shorter side. Reading the question, it sounds like the left dislocated hip is the longer hip.
The right might be the longer, so the left would be shorter and dislocated. If I'm reading this correctly.
Not as a cop out, but I think I might just have to see the child to really kind of understand. But my quick answer would be a shoe lift on the shorter side, if they haven't already tried it. There's also some less invasive surgeries you can do to try to equalize the limb links. And then always a conversation of, depending on how old the child is, potentially reducing the hip just to try to improve longer term function. But again, that really depends on the age of the child, how much motion they have in the hip. There's a lot that goes into that.
I'm getting clarification. Yes, the left is shorter. And the second question follows that. Any tips or tricks to get him to enjoy his AFOs longer than an hour at a time?
Oh, that's so hard. I would just make sure that they're comfortable. They do need to push a little bit because otherwise they're not holding the foot correction. And so I would encourage, if you're, I tell parents, let's aim for 23 hours a day, But if your hands are on those feet, that counts towards your 23 hours. So if you are stretching those feet, you know, if your hands are on those feet and you're stretching them, or you're practicing standing, or, you know, any of those things, and you're actively paying attention to the feet, that counts towards those 23 hours. So, so my encouragement would probably be just to try to up the stretching if at all possible, and then maybe just have an orthotist take another look, and just make sure there's nothing that they can do to make the braces a bit more comfortable without compromising the hold that they're trying to accomplish. So yeah.
All right. Next question is, my 10-year-old is starting to show greater contractures like when he was born. What can we do? Back to OTPT question mark?
Yeah, that's definitely where I would start. If you're not plugged in with the orthopedist, I'd circle back at 10. There's probably still some remaining growth. So if we're talking about a contracture of the knee or the ankle, there are things we can do, even like guided growth around the knee, where we slow down the growth on the front of the knee, allow the growth on the back of the knee to continue, and try to get that knee straighter again. But yes, until we're done growing, recurrent, you know, the contractures are going to try to recur.
All right. Does Shriners ever do intensive therapy sessions, like a week long, all day kind of thing?
Yes, we sure do. We kind of have a hierarchy of which patients we use for those, but we do, our post-surgical patients are always going to get those slots first. But then we do often when I see a child with arthrogryposis and you know, I need to understand more of how they function, how they work. I'll lean on my therapy friends. I'll send them to therapy for, you know, a couple, 3 days, sometimes a full week, just to work with them, help me to understand what are their strengths, and where can we help them. And that usually gives me a lot of good information to then develop a plan. Apart from that, say you're doing pretty good, but you just want to like really refine, I don't know, even like your feeding skills or your ability to put your hair in a ponytail. Yeah, we can do week-long intensive OT and PT to try to shore up some weaknesses.
Great. All right, can you speak specifically to how you treat AMCers with straight knees?
That is a great question, and I'd say that's one of the unanswered questions in orthopedics. So I'll start with that I hope I have a better answer 20 years from now than I do today. So as with most things, it depends on the age. If it's a baby and I can truly tell where the arc of motion is, I will try casting and or splinting to try to get some bend. We have to be mindful that a lot of our AMC kids have external hip rotation contractures. So what you think is the front of the knee may be actually the inside part of the knee, and you may be creating some instability that you're not intending to. So we have to be very careful with that. Moving up an age category, you know, if they're a bit too old for the stretch casting, I'll be honest, I don't have a ton of experience because I'm always I think it's a tightrope, and our kids with straight knees are going to be better standers and walkers because they just have something going for them already. But around 10 years old, when they're tall, now all of a sudden they have trouble sitting, or sitting in an airplane or a movie theater or a car that's really tight. And then, you know, whereas their long legs or their straight legs were helping them, now they're hindering them. And so the tightrope is, though, that a lot of our surgeries to help to increase flexion can also weaken that quadricep muscle, that knee extensor muscle. And so we take a kid that maybe needed just only short braces to walk, and now we've weakened that, you know, we have the potential to weaken that muscle, and now they might have to wear a long brace to walk. So it's a bit of a tightrope. And so I think it requires very careful surgical dosing. There's really not a one size fit all that, okay, we're going to do this major quadriceplasty or this anterior knee release. And I could say there's really not a lot of studies done on that specifically. There's a ton more studies done on how to make a bent knee straight. And so I hate to kind of give a fuzzy answer, but it's a work in progress. It's definitely one of my unanswered questions. I think Dr. Van Boss would agree. It's also one of his unanswered questions. And And so we owe it to you guys to find a better, a better answer. So work in progress, I guess, is my final answer. So.
I think we appreciate that. We know our kids aren't one size fits all, so we appreciate that ambiguity and study and research and drive. And now that's a question the community has. You can.
Mm-hmm.
All right, next, would you recommend continued upper and lower physio for adults with amyoplasia? And then the question continues, is there any way to get in touch with Asher's parents? I think my son is similar to him, would love to get in touch with them.
Yeah, let me start with the second one. I just would have to reach out to Asher's family. They agreed to be part of the study. And so I would just have to reach out to them. So you are always welcome, anybody that's on here, to email me. I think our folks here can get my email address. But I just want to respect, they agreed to be part of the presentation. I want to respect their privacy further from that. And then the first question about long-term physio, maybe I think it's always a great idea for my older kids to, once a year check in with a physio or a physical or occupational therapist, and just they might need some new equipment or just like, give me a new set of exercises. I think most all of our children and adults with arthrogryposis and amyoplasia are very much self-starters. Like they're very motivated and they want to succeed, and they want to just, they're a lot of them are very, very on top of what they need. And so, if they have a good home exercise program and access to a gym, I don't think they need to be in physical and occupational therapy every week like they do when they're children. But I think, checking in every now and then and saying like, hey, I'm starting to get a little twinge in my back. Can you look at my posture? Can you look at my walking? What are exercises I can do? And that goes for typically developing adults too. Maybe every now and then we need to check in too. So, yeah.
Okay, great. And yeah, I'm sorry. I do think that was two different questions that got squished together. The next one is, I know there are a lot of different syndromes under AMC, but do you have any specific experience with Larsen syndrome? Also, what does it take to come to Shriners for a second opinion?
Yeah, so yes, Larsen syndrome is one of those tricky syndromes because so much of their body is loose jointed, and then they'll have like the most stiff club feet I've ever encountered. So that syndrome and Beal syndrome, I think, have some overlap. So yes, we do have experience with that. It takes loosening up the stiff joint and providing support, often in the form of braces on the loose joint, to try to set the child up for improved function. So yes, we do have experience with Larsen syndrome, albeit not as common as like our amyoplasia, just because they're much more common when it comes to the numbers. With regards to becoming a patient at Shriners, you can call our registration number and just ask to fill out new patient work. You don't need a special referral. We take self-referrals, and you can do that either online or via the phone. And I apologize, I don't have those numbers in front of me. So, but it's pretty, I believe it's pretty easy just to look up through like Greenville Shriners, or where, the Shriners close to where you live.
Okay, great. The next one's not a question, just a thank you to the Greenville team. We found them later in my child's life, and hope is definitely the correct word for what they give you. So that's sweet. They are big on it's a marathon and not a race. Oh, back to what you were saying about the journey. They really take time to treat each child individually, and it's so much appreciated. We went through an amputation with Dr. Hyer, and her team have been phenomenal. Even with being states away, the therapists really make such a big part of the team. And just some appreciation your way.
Thank you.
Next question, is there any evidence that points to AMC being genetic?
Again, if we go back to our different types, currently we don't have evidence that amyoplasia has a genetic cause, but our other types of arthrogryposis often do. specifically our distal arthrogrypotic or distal arthrogryposes. That group tends to have what we call an autosomal dominant type of genetic component, meaning that just one parent has a copy of a gene and passes it to their child. So some of our other more rare syndromes tend to be that autosomal recessive, just meaning two parents have to have a recessive copy, and then it's passed on to the child. So it really just depends on the type of arthrogryposis. But again, our children with amyoplasia, we don't have a known genetic cause as of yet.
Great. And I have a question from Facebook Live. How long do you keep taking surveys and data on AMC children you've worked with? Is there a particular time frame, 10 years, 15 years, in which you stop keeping tabs on AMCers' journeys from childhood to adulthood?
I'm younger in practice, and I think that reflects my population too, that a lot of the kids I'm treating just are coming to me younger. And so I plan to continue to learn from them until they are skeletally mature. Now, the appointments will decrease in frequency. You know, I don't need to see a 16-year-old girl as frequently as I need to see a 6-month-old girl, but it's not to say I owe it to you guys to know what I do to an infant or a child is worth it when they are a young adult. And so there are some challenges with that, given our setup at Shriners, that we tend to transition to the adult world after 18. But I hope to do better. And I hope also just that to have relationships with these families to where, yeah, even though they're not technically my patient, I still hear from them and hear how they're doing. And so yeah, I've only been in practice for about 6 years now. And so I plan to continue watching these kids and seeing how they're doing. So I don't really have like an endpoint yet as to when I'll stop surveying them.
All right, great. I think that might be the end of our question time and the last question I have on my list anyway. So I really want to just thank you so much for your time. And I think you are available over email, you said, correct? If people wanted to ask you questions. Yeah. All right, and then your email is available through the Shriners website, I assume.
Yeah, I can give it to Michelle or you or Ani, and we could just, we can just put it. Maybe we'll just put it on my bio. Will that work? Yeah. Okay. They're giving me nods. So yeah, we'll just put it at the bio. So yeah, I think that's probably a good way of getting in touch with us here at Shriners.
Awesome. And thank you again so much for your talk. And I'm so excited that you'll be around a while and working with AMCers. And we really appreciate your time today, and we appreciate your practice, and we appreciate you. And
yeah, well, thank you. This has really been an honor and a pleasure. So I look forward to listening to the rest of the conference. So thank you everybody for your time. And please stay on for Dr. Nichols' talk, because I'm sure it's going to be fantastic. So
yeah, I'm looking forward to it as well. We're going to take an intermission. Dr. Nichols is finishing up surgery and running a bit late. So unless you want her to give her talk like this, we're going to start at 8:30 instead of 8:15. So during our intermission, go ahead and relax, get some snacks, use the restroom, and then come back at 8:30 for our next speaker.
Okay, I apologize for that. Alexis, I'm sure you saw me frantically waving my hands around and pointing. I was just on the phone with Dr. Nichols, who is, well, she had her team put her on speakerphone in the OR to remind me and confirm that she is still actively working on her patient. So she is doing what we would want any medical professional doing, and 100% focusing on that patient.
Absolutely. You muted though.
Oh, wait, can you hear me now still?
Yes.
Did you hear that whole, or just, did you hear any of that?
Stopped at what we want her to do for her patient.
Right, exactly. So I do have a message from Dr. Nichols. I promised I would relay this on her behalf. She apologized profusely to all of the attendees who were out there waiting to hear her talk. She is so incredibly sorry that she couldn't be here live, but again, she had to focus on that patient right now. I told her not to worry. If you're willing to type something into the meeting chat and just let Dr. Nichols know that it's okay that she couldn't be here live. I know I will share that with her, and I think that'll make her feel a lot better. She feels terrible, but we are going to work with her to privately record the talk and post that video as soon as possible. I have an appointment with her tomorrow, so we will get that up. So again, if you're willing to share a message in the chat and just let Dr. Nichols know that it was okay she couldn't join us because of that unexpected surgical delay, I know that would make her feel a lot better. Alexis, I'll turn it back to you for anything else you might want to share with the audience before we do our closing reminders for today.
I just wanted to thank you, Jean, for handling this last second, and I'm really excited for Dr. Nichols' talk to be recorded and given to our membership. And if anyone has any questions for her, definitely let us know and we will pass those along. And I think the DuPont method is just amazing. And I see, as I'm scrolling down in the gallery view, I see DuPont people waiting to hear her talk as well. It really is a great team over in Delaware there. And I just wanted to send a special thank you for Brandon and for Alex, who have been moderating our Facebook Lives and funneling your questions in and keeping on top of that. And Jean, thank you for juggling so much, putting those links in, getting the questions out, navigating, calling an OR during surgery. This is obviously, things happen, and we are definitely all one big family and all one big team here, and together in heart, even when apart, even when in surgery. So thanks again, and just a reminder that we will start up again tomorrow, same bat time, same bat channel, and with our next round of speakers, all AMC professionals. And we really appreciate you coming, and we have the team, the Loon crew has worked so hard to get this up and running, to get it virtual when it was all in person, and to make it accessible and free, and just getting information out there to our families. So just a really big thank you to the Loon crew. And then Jean, if it's possible, maybe we could open up the chat just so folks who did show up can talk to each other. I see a lot of familiar names, and just say hi, just since we have the Zoom time. And then we'll be closing up around what time you think?
I think we will go ahead and close up here in about 5 minutes or so. So just as you said, we have put the meeting chat open to public, which means you all can chat back and forth. If you'd like to come on camera, go right ahead. If I disabled your camera earlier, you can raise your hand and I'll help re-enable it so you all can come back on camera. And we did have someone who suggested we do an impromptu dance party and send the video to Dr. Reed to let her know that we're okay. And so I think that that's a great idea. I'll see if I can find some more fun music to play while we allow you all to come on camera, wave hello, and chat a little bit. But Alexis, I just wanted to thank you as well as Dr. Hyer, who joined us for today's session. And I have a small helper who is coming over in my home to help me close out the session today. But just a quick reminder, they will carry on for the rest of the week through that schedule that was just posted, and the recorded talks will be available to play on demand on AMCSI's website. So we will be posting them after the virtual conference, and that includes the recorded talk for Dr. Reed. So again, we apologize she couldn't be here live. And we've got a couple of people. Rini mentioned that she texted with Dr. Nichols, and she's really sorry and very sad. But just like she said, we all know things take much longer. And as many of you already chatted in, you know, as the patient or the parent of a patient, you want your doctor's undivided attention. And we are so happy that Dr. Nichols did that for her patient tonight. So that's absolutely right.
Absolutely. And hi, everyone, especially those with babies. AMC babies must be on camera. It's a law. I don't make the rules. I just enforce them, babies. We're getting some messages about Dr. Reed going above and beyond for her patients as well. Very, very positive. These are giants in the AMC medical community, so definitely look forward to their talks. And thanks for those covering your screens. It's so good to see you all next year in person. It's in person, and from what Michelle's been posting, we're gonna have elevators and accessible floors and
Oh, I see some AMC babies. Is that Monroe? I think maybe. All right.
Nichol.
So again, we'll leave it open for just a few more moments, but feel free to come on camera, wave hello, and then go. Oh, it's her sister Sloan. I see. Thank you.
Little small for Monroe.
Hello. You know, while we're waiting, y'all are welcome to guess where you think conference might be. It's never too early to start guessing.
Is it in San Diego? Can it be in San Diego? I think we should start that rumor now.
I'm going to lead in with Earth. It's somewhere on this planet. I think that's a fair guess. Oh, wait, Ani's muted. Good thing. Here we go.
It's in Cowpens.
Every year.
I don't live there anymore.
No, that's,
Then someone's going to be surprised to see us all when we show up.
Yes, Atlanta.
yes, Brandon. There's
Somewhere
probably a
near
Chipotle near.
Someone get that man some Chipotle.
Yes.
The running conference joke will now be Chipotle.
That's
Mhm.
right. Where's conference going to be? Chipotle. I think it's a fabulous choice. Oh, it looks like we've got groups. Again, our Arthrogryposis group from New Zealand has been on, and that's awesome to have you guys
That's so
joining us.
exciting.
Hi,
So
Tag.
happy you're here.
Love seeing Dr. Fromberg here.
Yes, I've seen a lot of fun names as I'm looking through. So it's exciting to see so many of the professionals who have joined us in the past, who are joining us now. Some that'll be presenting later this week, some who haven't. We have such an amazing group of professionals that step up every year. And they donate their time, their talent, their knowledge, and we couldn't do this without them. So they are appreciated more than I can ever express. And, you know, we all want them taking care of those kids that are on the table, the adults that are on the table, that's obviously first priority for everybody. So we are just very thankful for all of our speakers.
Absolutely. Hi, Rod. Hi, Alex. Oh, I have a guest from Jan for Atlanta. And I think, Michelle, you said yesterday, Atlanta is on the table at some point, correct?
Atlanta is on the table at some point. Because of our cancellation this summer, we did rebook with them, but I'm not telling you when.
That's only 3 hours for me, Michelle.
That's good, because then all of the treasure will come to you.
Ooh, wait, but I have a special tip, Michelle. Kirsten says that the Chipotle headquarters offices are in
See,
New
Dr.
Beach,
Nichol.
California.
Hi, Dr. Nichol.
Oh, look at Hi, Dr. Nichols.
We love you.
We love you, and everybody is very glad you are doing what you're doing. And we will watch you after when you are
Yes.
done what you are doing. Everyone says thank you.
Bye.
Bye. Thank you so much for dropping in.
No.
Well, what do you all think? On that note, perhaps we call it a night now that we have confirmation that poor Dr. Nichols is still in the OR trying to finish up her case. Alexis, any final thoughts you want to leave with the audience before we close things out today?
Just, I love you all, and be sure to register if you haven't. We love the engagement. Tell your friends to register, even if they're on the Facebook Live. It helps us to know. And we have a few more registration spots left. And we will see you all tomorrow night.
And if you see the post on Facebook, do me a huge, great, big, gigantic favor. Like it, share it, everything, so we can get the message out to as many people as we can. Thank you. Brandon,
Thank
I'm
you for
sorry I
coming.
took your job.
Thank you for
No, it's
coming,
all good.
everyone. and
Teamwork.
have an amazing night.
All right. Good night,
Bye,
everybody.
Heather.
Thank you, everyone. Good night.